Hi, welcome to day 3 of the summit. I am Dr. K-Mac, and tonight we will be discussing discussions surrounding COVID-19 policing and racial disparities. So I have 2 lovely guests that I can't wait to jump in the discussion with. First up, we have Dr. Ken Redcross. Dr. Ken Redcross is a board-certified internal medicine physician and completed his medical training at Columbia Presbyterian Medical Center in 2001. He provided care at his first job in Oxnard, California, then transitioned to Cedars-Sinai Medical Center in Beverly Hills. He launched his concierge practice in 2007 and established Red Cross Communications Incorporated, under which he provides medical education through media. Welcome, Dr. Redcross.
Thank you, Dr. Nicole. Thanks for having me on. I'm excited.
Thanks for being here. We're excited to have you. Next up, we have Dr. Bianca D.M. Wilson. She is the Senior Scholar of Public Policy. She is also the Rabbi Zaki Senior Scholar of Public Policy at the Williams Institute. Her research focuses primarily on system-involved LGBTQ youth, LGBT poverty, and sexual health among queer women. In addition to multiple peer-reviewed and institution-published reports, she co-edited a special issue of the Journal of Lesbian Studies that featured a multidisciplinary collection of work on health and other topics from the perspectives of Black lesbians in the US, Caribbean, and South Africa. She earned a doctorate in psychology from the Community and Prevention Research Program at the University of Illinois at Chicago, with a minor in statistics, methods, and measurement, and received postdoctoral training at the UCSF Institute for Health Policy Studies and the UCSF Lesbian Health and Research Center through an Agency for Health Research and Quality postdoctoral fellowship. Welcome.
Thank you. I'm very excited to be here. Thanks for having me.
And again, we're so excited to have you both here and to discuss this very important topic. I will start with you, Dr. Redcross, with the first question. And I want this to be more of a conversation. So as we talk about these different questions, please feel free to jump in and add any feedback or comments on each other's questions, and we'll just take it from there.
Great, sounds good.
That's good to me.
Can you please tell us what got you started in this area of medicine, Dr. Redcross?
Oh my, I don't know how much time you guys have. Let me first preface this. I'm an only child, so everybody out there watching this, get ready. I'm going to keep it short. So for me, everybody, it's interesting. I wanted to be a vet when I was a kid. I love animals, but animals don't talk that much, and I like to talk. So I decided at this point that I really wanted to focus on medicine, on healthcare. Even at a young age, I always wanted to make people happy. And I realized that through medicine, I'm able to do that. Even as a little bit of what you talk about with my bio. So my first gig, when you mentioned I went to California, I worked with migrant Mexican farm workers who worked in the strawberry fields, who were literally pulling up strawberries with their bare hands. And to me, that's why I went into medicine, to make a difference. And then you say to yourself, well, Dr. Redcross, you later went to Beverly Hills. So what's that all about? But that's also different, right? Because it's still focusing on souls, as I like to say, on people's souls. And that's what I'm able to do in medicine and in my practice. So it's been a lot of years of getting to kind of know thyself, to know that, even when I was young, I knew I wanted to make a difference, and medicine and healthcare has allowed me to do that.
Thank you. So Dr. Wilson, you can sort of lead us on your pathway as well. Like, how did you get into your career, and how did you get to the point where you decided to dedicate your research to LGBTQ issues?
Yeah, I guess I could go way back too. Even as a teenager, I was actually a peer sexual health educator, and started that very young under the mentorship of community organizers, where I was raised in San Diego, and so knew when I went to college And then graduate school, I was pursuing an education that would help kind of do that type of work, but on the research side of it. So I knew I wanted to do that very young. And my interest in sexual health and sex education led to a focus on HIV. And once I was really embedded in the HIV prevention research world, it was it's a clear standout. It still is to this day, who is most affected by the HIV epidemic in the US, and that was Black, gay, and bisexual men. And so that really kind of anchored me in LGBT research at that time. And honestly, we know to this day, most LGBT research is still funded through HIV mechanisms. But, once starting that area of work and working in HIV prevention with Black gay men, it became really clear there were a lot of other kind of parts of the community that received very little attention, including lesbians, youth of color, and low-income LGBTQ folks. So, that really kind of kept me moving in that direction.
One quick thing. It's interesting that Bianca talks about that, everyone, because then I kind of go back to my career. I've been in practice for about 20 years now. And so I kind of, show my age a little bit there. But it's interesting because I remember when the HIV epidemic was at its height when I was getting started, where we knew nothing. And to see now the marvels of what healthcare has been able to do, to Bianca's point, with all of her work and people like her who are researchers, that's why we are where we are now, to where HIV has almost become a chronic disease at this point, kind of like managing diabetes or any of those things, because we never had anything in our tool chest to make a difference. So it's due to the work of Bianca and so many others that have done some of that research that have seen this kind of develop. So it's pretty amazing to kind of hear her part of it, because I'm on a different spectrum of it.
Yeah. Yeah, and I imagine, Dr. Red Cross, on the medical side, like you said, we have the tools now to think about it as a chronic condition, and yet we still see Black, gay, and bisexual men having disparities around access to it. So it's like we're in this new place where it's not just about disparities related to getting HIV, but then it's kind of who's getting the benefits of access to the drugs and to that full continuum of care, and who isn't. And, so in many ways it feels like a really new day, and in other ways it feels like back when you and I started.
Yeah, and it's starting again now that we have the coronavirus or COVID-19 that kind of is just really shown a big light on the healthcare disparities that you're talking about in the gay and lesbian community. So you're right. It's different, but it isn't, right? It's still some healthcare disparities going on that we're hopefully going to talk a lot about and be able to share with a lot of folks who are listening and watching.
That's a great start, because as you were even talking about it, I'm like, wow, not that it's the same like you're saying, Dr. Red Cross, but just in terms of like we're dealing with something where you don't really know that much about it, but then you're also seeing these disparities in what communities are being negatively impacted.
Right.
And so it's like you're teasing apart two different things. Like, how do we treat this, but also how do we give people access to appropriate care and make sure that it's not disproportionately impacting these communities. And then I would imagine, and maybe we should just jump into that, but I would imagine even as we think about LGBTQ populations, that maybe there are different disparities even as it relates to COVID-19. So when we're thinking about COVID-19 thus far and its impact on the nation and the world, why isn't there more information about preventative measures?
Yeah, one of the important things is that there needs to be a central message, right? You can't go to war, you can't go to battle without having a plan. And if you don't have a plan, we're kind of, getting what we're seeing now. Now, the important thing for me, look, guys, it doesn't matter what side of the aisle you're on, right? This virus is agnostic, doesn't care. So we just need to have a plan together and how we deal with that. Now, when you look at the data, for instance, you look, and African Americans in particular, not necessarily gay and lesbian, but African Americans, all of us inclusive, about 12% of the United States, but account for over a quarter of the deaths here in the United States from the coronavirus. There's a lot of reasons kind of around that, but that's why this is the time when we can kind of point out these healthcare disparities, get some education out there, and get a plan around that for all of the communities to say, look, we have to do something about this because the coronavirus isn't going anytime soon, everyone. I am the most positive guy if you ever knew me, guys. So I'm not saying forever, but I'm saying we have to do some things first before we can start living life normally again like we all want to.
Yeah, this question is for you, Dr. Wilson. I guess both in terms of COVID-19, but also just in general. When we're thinking about LGBTQ communities, what are some of those unique contributors to poverty? And in my mind, I'm sort of thinking about even what role that may have as we're thinking about some of the disparities that we're talking about as well. And then along that too, if we could think about like what policies or services are needed to address some of these needs.
Okay, big questions. So I'll take some of it, but if you want me to follow up more, just let me know. Yeah, I mean, when we think of what's unique for LGBTQ people and poverty, and as Dr. Red Cross said, we need to be thinking about poverty and these other larger factors when thinking about vulnerability to COVID. And so poverty is one of those main things that we saw from the very beginning of the pandemic and is still the case today. So when we think about poverty as a major issue among queer people, there's actually some kind of similar experiences that my research shows, as well as some very unique ones. So some things that look similar, particularly to other people of color, is simply the experience of childhood poverty and that intergenerational poverty cycle, that we know that LGBTQ people are more likely to be poor than cis heterosexual people. But a lot of those folks who are LGBTQ experience poverty also as children. So they're actually coming from communities, many of whom are also people of color, coming from poor communities of color. So when thinking about that particular factor, policies that matter and interventions that matter are the same things that would matter to help Black, Brown, American Indian families in coming out of poverty. Equal pay, fixing the equity pay for women law and making that, making it easier to hold employers accountable, minimum wage. So the type of initiatives that we think about that are going to help communities of color in general are going to in turn help LGBTQ poor communities as well, because those are simply the adults that were children also in those families. But there are also some unique factors too for LGBTQ folks, particularly discrimination and bias related to LGBT status. And that includes all the way back as children and teenagers, like family rejection. In one of our interviews that we did, about 100 qualitative interviews in 2 counties in California, people talked about experiencing rejection from their families and that kind of being this cutoff of family resources that then impacted their, eventual low income status. Also, folks talked to us about experiencing discrimination in the jobs, particularly transgender individuals. Being discriminated, and gender nonconforming women and men, experiencing job-based discrimination, housing discrimination, discrimination in services. So, there we're looking at policies that extend some of the gains that we got from that recent Supreme Court decision, Bostock, which is in an employment context, but extending it to some of those other settings like housing, services. So, those are the kind of policies that we would look at that are specific to LGBT people.
Mm-hmm. And one of the things that Bianca just mentioned, the housing piece. So let me do this on the medical side, everyone. So what does it look like? Who's getting the coronavirus primarily? Well, it's those with particularly 4 or so disease states: lung disease, heart disease, obesity, diabetes, things that typically can run rampant in our communities, brown or Black or what have you, or underserved communities. The other thing that's really quite fascinating as we talk about all this, and we'll dive into this later, but if you look at all 4 of those disease states, they all are associated or could be associated with low vitamin D levels. So why do I bring that up now? Because when you look at the brown and Black communities, you look and about 80% of African Americans are low in vitamin D. Number two, then you have Hispanics, about 70% of them are low in vitamin D. The other thing that made me jump up and down when I realized, because we're realizing, look, vitamin D is not only about bone health, everyone, it's about immune health. So if you see how brown and black folks are being affected by this, and you know that a lot of those disease states are already in our community and associated with low vitamin D, and most of us have low vitamin D, you start to understand a little bit more of what could be going on. Now, vitamin D is not a treatment for the coronavirus. That's not what we're talking about. We're talking about supporting our immune system. And that's why I was saying I was jumping up and down when Dr. Fauci came on. So America's infectious disease doctor, what did he say he was taking when they put his feet to the fire? He said, I take vitamin C and guess what? Vitamin D. And then Fauci's taking it, I'm taking it. And I already knew the research anyway. So he was really just backing up what I already knew. So, you know, I joke around a lot with patients and everyone whenever I'm on air, because I want to issue a challenge to all of us. I want us all to know your vitamin D levels, to make sure they're in that right range, and recognize that in our communities, back to your point, Bianca, social distancing is a luxury. It's things that we can't necessarily do as much because of our housing situations and things like that. So, you know, these are all important kind of touch points that we all have to just continue to kind of take in and start doing something about them.
Yeah, no, I agree. And I think, like, when thinking too, like, you've given us such a great perspective on the physiological side in terms of those health vulnerabilities, but also, you know, adding to that on the structural side, like when we think about the relationship between, you know, the currently established relationship between weight and COVID, something that's missing in research, and this is in the larger medical literature, is really connecting those outcomes with the discrimination that fatter folks actually experience in the healthcare system. So the bias against fat people is well documented. The fact that heavier than average people feel uncomfortable going into care, and the likelihood that that might also be the group that doesn't even want to go in right away. And so, you know, to also thinking about some of these structural issues and incorporating that with our understanding of, like, the physiological vulnerabilities, I think is just core to bringing these aspects together for Black folks in general, and then, you know, also inclusive of that Black LGBT people.
Well, and especially in our community, I never ever say fat. I say either obese or I say pleasantly plump. What have you?
I say fat, but I'm a fat health studies researcher.
You are not. I don't hear it. I'm not. That's not coming out of my mouth.
That's fine. We say it because, well, no, in all honesty, I'll just put out there, since I use the term, and I know for some people they might feel uncomfortable.
I'm kind of
that it's like, it's descriptive. So it's like, it's kind of the way that we might think of calling someone Black or dark skin or gay might be seen as an insult if you think of that negatively. But fat is literally just a description, whereas clinical terms assume disease even when disease might not be present. And so that, just so folks know, you know, I understand. Dr. Cross isn't ready to go there yet. But
no, I'm teasing. But you know what? The reason why I kind of joked about it is because, you know, as I was mentioning, in our community, you know, lots of us like full figure women. That's not a problem. You know what I mean? And so it's different in our community to say, you know how it is. If you get there, even if you're a little on the thicker side, if you're not eating, it's like you need to eat more. You don't look healthy enough unless you're kind of fit. So there's a lot of little things that, you know, that is different for us when you talk about that. So you're right there, but it's definitely never tied to the discrimination part. You are 100% right there, and it should be. So that's a very valid point.
And something that came up on, I think it was the session from yesterday, as we're thinking about discrimination, like in the same way that people may be discriminated based on their size, like being discriminated based on their sexual orientation. So you're like adding all of these things where it's like discriminated on your race, your size, your sexual orientation, on top of all of these other issues, and thinking about COVID-19 and why our community is being disproportionately impacted. It's like, so many layers that need to be addressed, and not just, I think it's being highlighted with COVID-19, but we also know that these disparities exist anyway, like in other conditions as well.
No, you're right. It's just added another layer to things in a sense. You know, it causes a syndrome called weathering. Now, weathering is just like you guys would think. You leave something out in the rain, and what happens? It gets worn down. it gets rusty. They did a study on African American women who take, honestly, the brunt of all of this when they look at the studies. And so that weathering just wears you down, increases your reaction to stress, and stress causes dis-ease. I never say disease, I call it dis-ease, because that's exactly what starts to happen when we're always under so much stress. And especially in the gay and lesbian community as well. So you're right, all of these things all kind of intertwine to cause imbalances, things that we're looking for. And sometimes, you know, it's not always on the Western side of healing. Sometimes, you know, you can look at some alternative ways to get well also, in addition to some of the Western medicine.
So that reminds, like, even going back with the vitamin D piece, like you talked about, I didn't know Dr. Fauci was taking that. Now I'm sitting here like, oh, I need some vitamin D.
Yeah, I know, you see?
I wrote it down. I was like, let me.
See, if Dr. Red Cross takes it, a lot of people will be like, okay, Dr. Red Cross, but if Fauci takes it, I don't know. And that's okay. He's ID, so I won't take that personally. He's infectious disease, so I'm cool with that.
Yeah, but I did write it down. But are there like any signs or things that people should look out for when their vitamin D is low? Like, how do we know, oh, my vitamin D is low, this is something I need to address?
All right. Well, look, that's a great question. Okay, so let me let everyone know. So when we're talking about vitamin D, the important thing is to know your levels. As I joke around, I say get on my level when I'm talking to patients or other things, because I want all of you watching to get on my level. That level is between 40 and 60. So you're either going to go to your doctor to get your levels tested. You can go to a website, which is called thepowerofd.org. They have at-home test kits. So you can order a kit, do a finger stick if that's your thing, and do it that way. The other reason why I mentioned that in particular is that you can go to that same website and put in whatever your numbers are, and it'll tell you how much you should be taking. All right. So that's the big thing when we talk about that. Now, vitamin D story is an interesting one, because when you find people who are deficient, they don't necessarily tell you they have anything. You know what it is? It's when their levels get back up to the right levels where you start hearing, I have more energy, I'm sleeping better, I'm less fatigued, that sort of thing. That's when it becomes important to make sure your vitamin D levels are up. And those are the big things you typically hear from everyone. But once again, you don't know these sort of things unless you get your levels checked. And that's something that we're not always so good about going to the doctor, because we don't want bad news. Well, I tell everyone, I don't give bad news. I don't believe in that. And so we need to make sure we're getting those levels checked and understanding that the vitamin D story is about our immune support here, not just bone health. The vitamin D is good for the brain, which is why a lot of people will talk about a sense of well-being when they take their vitamin D. There's a receptor for almost every immune cell for vitamin D. So it's important that we kind of become better acquainted with why it's important, and especially for us, because a couple of reasons. Vitamin D isn't something that we get in our diet that's plentiful at all. You can get it from fatty fish, such as sardines. It's the reason why grandma used to run around with cod liver oil. She was a genius, because it's loaded with vitamin D, okay? But it's not easy for us to get each and every day. And our beautiful brown skin blocks out the sun's rays. So we're also not converting it as well either when the sun comes to our skin and converts the vitamin D. So we have a couple of things working against us. So that's why it's important to get acquainted with why vitamin D is important and why all of us should really be taking it, or at least know our levels.
We get free medical advice hour.
Right. This is good.
Who said it was free? Hold on now. Times are hard, girl. Times are hard.
They are.
Dr. Wilson, what issues would you say are particularly salient for Black people of color and LGBTQ people? I think we've talked a little bit about that, but if there's anything else that you could speak to.
Yeah, I mean, it's interesting. I mean, we kind of, in some way, we were moving the conversation toward food and nutrition. And, I've already mentioned just poverty generally, high poverty rates, homelessness, higher homelessness rates, but also higher food insecurity rates. So LGBT folks tend to experience food insecurity at higher rates than cis straight people. And within that, out of all the other ethnic groups, Black LGBT people tend to experience food insecurity even more nationally. So, that's a major issue that really stands out. I mean, there's other things that sound less, sad and depressing that do come up in research, like sense of community. I mean, it's clear really as a great sign of resiliency that Black LGBTQ folks continue to create community. And, research of colleagues of mine have demonstrated that, when they say, Black folks don't go to the predominantly white LGBT community, that's true, but you need to qualify that with predominantly white. It doesn't mean that they're without community. It means that they've actually created Black LGBTQ spaces. So, that's really a core kind of positive issue or sign of resiliency that, maybe we can continue to capitalize on when trying to address some of these other issues. But a lot of the other ones I mentioned, discrimination, those structural issues. Oh, one other thing, parenting. I realized we started the call even today talking about, my kids running around somewhere. That is something that while Black LGBT people might not, they are not parents at the same rate that Black hetero cis people are parents, but at far higher rate typically than white LGBT people. And
Really?
so, parenting and Latinx folks too. So, just a higher rate of parenting, having kids, whether it's from previous heterosexual relationships or, current same-sex partners, are more likely to have children. So parenting, it came up a lot in our poverty research. It was everywhere. Just navigating child custody situations as like a lesbian and being discriminated against, navigating just having children and figuring out how to feed them when you're food insecure. And so that extra element of what it meant to deal with all these structural issues was really present for LGBT people of color in the study.
Bianca, have you seen that the community pretty much is united as far as, like you're talking about the food insecurity, for instance, like in the LGBTQ, is everybody kind of together, or are there little factions sometimes that make it a little challenge to kind of bridge that gap to get a whole message or, some push the ball forward a bit?
Yeah, you mean like to tackle these kind of big structural
Yeah, especially because these are big ones. These are big ones.
Yeah, I mean, I think, I would say I see the same kind of stratification that we see in organizing more generally in the US, that you have folks that are wealthy, both LGBT and straight,
right,
and cisgender who,
excuse me,
are not as interested in that part of the community. I mean, when we think about a Black middle class and upper class ethic of not necessarily, starting to demonize and think about Black low income folks as like, well, that's them and that's not me. You see that same thing happens among LGBT folks. So kind of the minority groups that make it up are quick to demonize and, not think about the structural forces impacting the rest of the community. So I'd say that similar kind of stratification has happened, and there have been critiques of particularly LGBTQ folks of color, Black folks saying, hey, we understand gay marriage was important. However, we're over incarcerated, we're homeless at higher rates, there's poverty. Right. Let's talk about those issues.
Sure. All right.
That's something that we wanted to go into as well, since you sort of went there, Dr. Wilson. We'll just keep going down that path. So we have seen example after example of racial disparities in the criminal justice system. Can you talk about how LGBTQ people of color are impacted by policing and incarceration?
Yeah, I can speak to the incarceration piece more. Our research with colleagues that I have at the Williams Institute, we found that both in adult prisons and jails, as well as youth detention facilities, sexual minorities, so LGB, we don't have great data on trans. So the issue with good data is like is a thread through all of these issues in terms of how well we can track, including going back to COVID. But in this case, in thinking about LGB people, are more likely to be incarcerated or are overrepresented in jails and prisons and youth detention facilities. And again, what's really notable about that is sometimes when we say that, people start to think, if I said LGB, it's like in their mind, they're picturing white gay people necessarily. And they don't realize that you're still seeing that disproportionate Black and Brown and American Indian population among the gay folks, as well as the hetero folks in those prisons and jails and youth detention facilities, meaning the racial disproportionality is mirrored in both communities and represented in those systems. So, you know, that is a major issue. We've seen that disproportional, like, overrepresentation. Now, looking at the policing, the issue is research hasn't really shown how we get there. Is it, you know, so questions that we have, these are more like unanswered questions. Is it about higher likelihood of police interactions, higher likelihood of arrests of LGBT people? Is it about what happens at sentencing and biases there? Or is it about probation and not getting out? Those are questions we still have to answer, I think. But the incarceration piece, that's documented.
Wow. Dr. Red Cross.
Yes, ma'am.
So with everything that we've talked about, we've been hearing messaging, like even tonight, right? We're going to figure out our vitamin D levels and make sure we're taking proper dosage of vitamin D. But we're also hearing a focus on, you know, having a healthier diet, exercise, proper nutrition, and things like that. And I know we're heading into like cold and flu season and, you know, more, I see the maps every day, like, oh, we're having more cases of confirmed cases of COVID-19.
Yeah.
So with that, is the understanding, like, if we were all at our best, you know, with our immune system and our health and wellness, would the COVID cases be lower? Or like, is there really a connection between the two?
You know, there really is. You know, one of the things I always talk about is when I'm talking to patients, I say is that food is medicine. And you always hear that, but it really and truly is. You know, when you're talking with patients and you're wanting them to get over a cold, I'll talk about tea and adding fresh rosemary, things that are, as I like to say, that are a little bit closer to the earth. And so that's one thing we need to think about. Look, my whole goal, I'm a Western trained physician, but my whole goal is never to have to write a prescription. And that gets back to, once again, staying closer to the earth. And that comes back to the importance of nutrition. I also talk a lot about movement, whatever that is. I joke when patients say, well, Dr. Red Cross, I work hard at my job. It's like exercise. I'm like, no, that's not going to count. I want to make sure that when you're exercising that you cannot speak in full sentences. That's exercise. And then there's also the third component besides just the movement and the nutrition, and it's your spirituality. Whatever that is. It doesn't have to be a religious component, but what I mean by that is just time to take your time to be about you, whether that's through meditation, whether that's through chanting, whatever that is. All of those are all important to kind of put the pieces together to make sure that we're staying healthy and well without prescriptions potentially, unless it's for some disease states where we know that that's best practices.
Oh, that's really good. Okay. Dr. Wilson, so this November, the Supreme Court will hear oral arguments in a case about whether religiously based child welfare agencies can discriminate against same-sex couples who want to foster or adopt. What specific challenges do LGBTQ youth face in foster care? What policies or interventions can help improve the lives of vulnerable LGBTQ youth?
Well, I mean, similar to incarceration, we know that LGBTQ youth are overrepresented in foster care. They make up 20% or more of the foster care population, keeping in mind that they only make up about half that of the general youth population. So we know that they're overrepresented. Again, just like with incarceration, we know that, you know, 80% of those are kids of color. Over Black and American Indian youth in particular in California are overrepresented in the foster care system. Our research has shown that once they're in the system, they report that they feel they're treated less well. They're more likely to have been homeless at some point in their life. They're more likely to get moved around to different placements and report higher levels of psychological distress. And, getting back to that stress part that Dr. Red Cross noted, I mean, that's also a very consistent theme through a lot of our work, even on discrimination. And, colleagues of mine like Elon Meyer and folks who have established, minority stress models, and this understanding that experiences with those kinds of psychological distress have physiological outcomes and just, the standalone mental health outcomes, which are problematic in themselves, even if they didn't lead to physiological problems. So we see that among our LGBTQ foster youth.
Okay. And then I guess one of the last questions that we have is thinking about this economic fallout from COVID-19. And what do we need right now? And I guess thinking from multiple perspectives as we have tonight, like going back and forth, what do we need right now to adequately address the needs of vulnerable populations of LGBTQ people?
Yeah, I mean, I was, thinking about what Ken was saying earlier around, when we were just talking about the role of housing and, crowded housing in, on aiding the transmission of the coronavirus, the novel coronavirus. And, so where we already know that African-American folks in general experience housing insecurity, which requires, particularly in areas like where both he and I are in LA, a lot of people already doubled and tripled up just, even when they're making incomes that would be seen as middle class in other parts of the country, they're doubled and tripled up just to have some housing. So you can imagine what's going on for families who are low income. We already know that that's the case for African-American folks in general, and then LGBT folks in general. So, COVID-19 is not going to make this better, and is probably, it's an easy prediction in the absence of good data, going to make it worse. And I say good data related to LGBT people because we don't have good data on who's getting COVID, but we can only imagine that for those who are, that they were already vulnerable to all these structural issues, that it's going to get worse.
Yeah, you're right. And you're right. A lot of the data when they talk about as far as African Americans, about 25% of the deaths and all these and Latinos as well, and those challenges. You're right though, Bianca. It's not really parsed out as to gay, lesbian, any of that. You're right. And that's very valuable data. It's interesting, but my practice is based on I make house calls. So I go see people. I'm in the homes and I'm seeing the situations that are there, especially, New York is only, but there's not a lot of space and so forth. And it's one of these things that's really perpetuating. That's why we get back to, we've talked about all this stuff about social distancing, hand washing, mask, and then we mentioned vitamin D. These are all the things we have to employ. But masks are huge. Look, like I said, it's so tough for me, everybody, to get the argument because it's a respiratory virus. So I don't get the beef. But the point is that, we have to wise up, and especially in our communities all together to say, our situation's a little bit different here. It's a little bit different, but that social distancing is the hard part for us. To see how we can do that. And you also look at a lot of the studies, it was almost like, I don't want to misquote this, guys, but the study I was reading was almost like only 30% of African Americans and Latinos can work from home. So therefore, what's happening is they're out in the front lines doing their thing, trying to make ends meet and coming back home again.
Right.
So it's complicated.
Yeah, no, absolutely. When you think of how dependent the service industry is on Latinx folks, particularly, in California and many other states. It's like, of course, it's going to be the group with the highest rate. Like we got folks out there and we're not giving them the materials that are needed. And
you're right.
And then to your point around gathering and social distancing, I mean, earlier when I brought up the significance of community and sense of community, as a barrier, as like a protection against all these like forms of prejudice and discrimination and stress that folks experience. Well, what does it mean when we just say you can't have that community, you can't have that family right now? And people are struggling with that. What does that mean to be without that? And to say they need to remain social distance in order to stay healthy, but struggling with how to keep community, and not everyone has the technology to feel comfortable that they can do that, all with videos, with internet that works perfectly. And, so I do, I agree with you. I think that's another piece too, that we have to continue looking out for. It doesn't mean that we say, well, that's okay, forget about it, don't social distance. But we do on some level have to acknowledge that in an effort to, as people are not social distancing, to some extent, a lot of that is about wanting to remain connected and trying to figure out how to do that. And the communities that we're caring for are communities that particularly need connection and support right now.
Absolutely. And that's the tough part, right? I got a question on social media earlier today, just to this point when they were just talking about what's going on. And I like to try to help people all around. And they said, Thanksgiving's coming up. And what do? I want to be with my family. We're talking about these things that are important, but there's an emotional component, right, guys? I mean, there is so much to touch, and you can't do those things, or you have to be careful. And what I told her was one of the better ways to potentially do this, everybody, is to kind of create like kind of a love bubble, right? A bubble around those people who are kind of in your crew, in your area, who think alike, who recognize the importance of a mask, who at least recognize that you're all on the same page, so that you can kind of be around one another. Look at the sports, we're able to do it with a lot more people than what we're all kind of talking about in that bubble. So you got to kind of create that. And I call it that love bubble, because that's what you start to miss when you feel a little alienated and, like, gosh, I just want to get back to normal again.
Yeah.
I like that suggestion. I know even in the work that I do, like starting to hear more people where family and community and those people you connect with are a major part of your happiness, your wellness, your support. And so if you're saying, well, here are people who this is important, it's important to have touch in this community that you've developed, and then it's taken away in a lot of ways, people are struggling with that. And then the flip side of that is the loneliness, the isolation. Then you start to see the decline in that way. And so I like your suggestion of one, having that love bubble, and what does that look like, and who are the people. You see it with like the schools, almost like where a lot of kids are doing like pods. So these educational pods that they trust can still be able to connect. I'm gonna use that one, Dr. Red Cross.
It's not patented, it's good. It's for all of us.
That's a good one as we're thinking about the holiday season, the winter. Well, you all are in California, so it's a little
different. In New York. I'm in New York.
You're still out there.
And you know what? I love New York so much, I kept my New York cell phone.
Oh my goodness.
So that's why. That's what that
I'm only in LA, I guess.
You're only in LA. But you know what? I used to go back and forth, but COVID's put a kibosh on that. But I get it. And in very similar situations from LA to New York, tons of people, not a lot of space, a lot of brown and black folks that are having challenges. Same thing, whether it's the East Coast or the left coast, as we say.
So we're getting close to time for questions from social media. So if there were any takeaways that you want the audience to get tonight, what are some important points that you would like to highlight for our audience?
Ladies first. Bianca, you like to take that, or you want me to jump on?
I mean, I guess I'll just say that. I mean, I think the main takeaway to me is that, I'd like folks just to keep in mind that some of these structural issues that we've historically thought of as impacting African-American health and mental health disparities are also highly impacting LGBTQ people. And then to not forget all the folks that are at the intersection of those two communities are being hit on, both sides of that, and, multiple sides if we're talking about trans and trans folks and women. So, a message to me that I also take away from this is just the significance of working across disciplines and perspectives to combine the structural, the biological, the medical,
Right.
in our efforts to address these issues.
Yeah, you're right, because they don't really work in just silos, do they? It impacts all of us. So, I think the main thing on my end, Dr. Nicole, is just to make sure that all of you out there watching and listening understand that your health matters. Sometimes it may not feel like it. You go to that doctor's visit, they rush you in, they rush you in and rush you out. They're not listening. No, your health matters. And we talked about that today, whether it be through a prescription for some docs, if you need it. And we talked about something closer to the earth like vitamin D that can make a difference that we can control. And so we have to educate ourselves. And so I think that's the big takeaway for me, to recognize that our health matters. And we need to take it, because no one's going to give it to us. We're going to have to really, make a little bit of noise, a little bit of fuss, to make sure we get what's really coming to us and what we deserve to receive.
Well, thank you both. And we'll get some social media questions from Chad.
Okay.
Okay. Can everybody hear me okay?
Hear you well, Chad.
Perfect. Okay, the first question is for Dr. Wilson. This comes from Sharon T, 44. And the question is, are there childcare agencies that only support children from the LGBT community?
That's a good question. It's a good question.
Child care agencies. So I'll assume that, here we're talking about like daycare and preschool types of services. Chad, if you understood the question differently, let me know.
No, I think that you're right. I think that is where it's coming from. Any type of childcare programming, agencies, or education system, yes.
Honestly, I don't know of any. And yeah, the only thing I know of are kind of these independent co-ops of queer parents that will, get together and create those systems, but nothing formalized. So I do know of, I guess you could say, pods or co-op groups that are saying we want like-minded people. We want our kids to be around other kids that, they're not being reminded over and over, well, what do you mean you have two moms? That can't be, things that like my kids have heard, and so some have like tried to create those types of pods together, but I don't know of anything formal. So let us know if you start one.
Okay, thank you for that. The next question is for Dr. Red Cross. And this question is, are there any key indicators that a person who identifies as LGBTQ can avoid regarding contracting COVID-19?
That's another good question. I'll tell you this, everyone. As I mentioned earlier in this talk, this particular virus is agnostic. And not only is it agnostic, it doesn't matter who you love and how you love. We're all kind of affected the same way, which is also a positive. I mentioned earlier, I'm always positive no matter what. And so it's positive in that we do the same things. We'll all get out of this thing together. So I think that's the important thing for us to remember. So I wouldn't say anything specifically, Chad. It's kind of this is a universal issue here. And if we all do the right thing, we'll all get back to some normalcy.
Thank you for that. All right, we have one more question for Dr. Wilson. And this comes from Mark C. Scott 6. And the question is, are there any existing financial opportunities that people of color from the LGBTQ community can pursue?
Specific financial opportunities. Well, I'll take that to be asking about whether or not there's maybe services that are designed to encourage and support efforts to get employment, or to start businesses. And often your local LGBT center does have some type of service like that. I mean, one standout community organization that I know of is called Trans Can Work. That is out here in California, but I know of similar groups like in Chicago, and I'm sure there's one in New York, that are designed to help trans folks in particular navigate employment settings and the job getting process, which can be particularly hostile towards transgender people. Now, with that said, I recognize that, you know, while LGBT people might be more likely to live in metropolitan areas, that's not where most of us are. We're in the South, where, you know, folks are everywhere in the country. And so that can be a limitation, that people depend on those services within those mainstream LGBT centers, but those LGBT centers don't exist in every city around the country. So hopefully that answers your question.
I think that was a good way to frame that. Okay, the next question is for Dr. Red Cross. And this question comes from Tomorrow52. COVID-19 uniquely affects Black LGBTQ. Are there any medications designed specifically for the LGBTQ people of color?
Well, I think this will get back to the same thing, and that the management is very similar. I wouldn't say any specific medications at all, unless we're dealing with different disease states. I mentioned lung disease, heart disease, diabetes, being overweight. Those are things that are risk factors from us. And it doesn't really matter what community you're a part of here. And so you're right, the numbers, and as I mentioned with Bianca earlier, you know, there needs to be better studies to show that, you know, what percentage of African Americans or Latinos that are getting COVID and dying, what percentage are of the LGBTQ? I mean, that's helpful information. You know, this has been great to even be on the show for me to kind of say, you know, that's a very, very good point, and it should be reported. So I wouldn't say a specific medication again, Chad, but I would still say it's disease state specific. And it's important to make sure that you have that relationship with your doctor. One of the things I'm passionate about is the bond between you and your doctor. I even wrote a book called Bond because of that, because I found that especially in our communities, you don't see that a lot. And I think that helps to improve our healthcare outcomes when you have a good bond with your doctor who you know is going to call you out if you're not doing the right thing.
Wonderfully put and said. Those are all the questions I have for from the audience on social media. So thank you.
Thank you.
Thank you.
So Chad, do you want me to do a closeout?
Yes, I appreciated that pause right there for editing purposes. So that was good. So yes, let's go ahead and do the closeout, and then we can call it a night. And before you do that, this was wonderful. I learned so much once again.
I did too.
This was beautiful, beautiful. So yes, go ahead and do your closeout. I'll go back to mute.
Well, thank you, Dr. Red Cross and Dr. Wilson, for all of the insight and knowledge that you gave us tonight. I feel like I learned a lot. I took some notes and have a lot of takeaways, both for my personal life, but also in my work as well, about how I can improve even what I'm doing with the people that I serve. And so I want to thank you all in our discussion about COVID-19 and the racial disparities that exist. And then for the audience, we hope that you're able to join us tomorrow night as we discuss diversity in corporate America, employment and housing, and we hope to have you be a part of that discussion as well. Thank you.
Great. Thanks for having us.
Oh, thank you so much.